Okay, cool. Thank you. It's getting towards the end of the day. I had a 20-minute talk. I'm going to try to compress it. Thank you, Paul, for giving us so many shout outs. We've really loved working with Simons, and our blood collection teams are best friends these days. So I'm Terry Jo Bichell, and I did get a PhD, but actually I started it when I was 50. I didn't get it until I was 57. I lead Combined Brain, which is a nonprofit consortium, and we're up to 100 patient advocacy groups, each one representing a rare genetic neurodevelopmental disorder. We're trying to get all of those groups to help each other so that they don't have to keep remaking the wheel, so we can go faster and faster to getting treatments to all these different disorders. So what I'm supposed to talk about today is endpoints, and why do we care about endpoints? Endpoints is pretty much the most boring topic that you could bring up at any conference. But anyone here from industry who cares about endpoints, please raise your hand. Okay, we got some hands up. Endpoints are a very big deal. And one of the reasons endpoints are a big deal is because we've had a lot of trials fail in the past 10 years, especially trials about neurodevelopmental disorders. And why is that? Well, one of the reasons for that is because we were always measuring what was curing the mice. We put the mice in the center of the pathway. We saw what we could do to help the mice, and we did a great job at making the quality of life of the mice a whole lot better. But the problem is we didn't necessarily actually measure the right things in the human beings that could show us that a drug was really working to do what people care about. And what you have to do to get a drug to pass through the FDA, you have to measure something that matters to patients. You have to measure something that affects how the patient feels, functions, or survives. And you have to measure a meaningful change. All of those have to be done in people. And so now we've learned to start from the people instead of starting from the mice and putting the people in the center. And hopefully that will help our clinical trials to succeed. So all of this is based on these instruction booklets that come directly from the FDA that tell us exactly how to incorporate the patient voice into the drug development process. They put out guidances all the time, but this was their series of guidance on the patient voice. And one of the most important things that they talked about, the FDA did, was you have to actually ask patients what matters to them. What's fascinating about what you all did here by having all the parents walk across the stage and tell us what matters to them is we got a picture of what does matter. And it seemed to me that it was communication, probably number one, behavior, maybe number two. Seizures were in there, but it wasn't as frequent as the behavior and the communication. I thought that was really interesting. And that's what happens when you actually ask patients and families what matters to them. So there's a way to do this. You write a paper from that type of study called a conceptual model. We did write a draft conceptual model. Kim Goodspeed's the first author. That's based on the scientific and medical literature. We still have to do the full conceptual model based on interviews to really find out what matters to patients. But even in the draft conceptual model, you can see that we found that communication was a big deal. Communication is really important to families who have kids with SLC6A1 related disorder. The other thing we found is that daily living skills are a big deal. And in fact, we had one family talk about changing diapers. Toileting skills and toileting abilities is a big deal. So that is another thing that's important to families. Those things could be endpoints for clinical trials. So what is an endpoint? So I have, one of my 5 kids has Angelman syndrome. And I went to the FAST Angelman Summit just a couple weeks ago, heard a great talk by Jennifer Panagoulias. And so I asked her if I could borrow some of her slides, and she told me yes, I could. So you'll see a lot of slides here attributed to Jennifer. She did a great job. So what is an endpoint? Well, an endpoint is an outcome of a clinical trial that you can analyze statistically to determine if a drug is working and if it's safe. It can include outcome measures, or it can include surrogate endpoints. This is where it gets really boring. Everybody should pinch themselves a little bit, try to stay awake for the good part. So what is an outcome measure? An outcome measure assesses the way a patient feels, functions, or survives. That's what the FDA cares about. Do you live longer? Do you feel better? Are you able to do what you have to do in your daily life better? An ideal measure captures what matters to families, to patients and caregivers. And on top of that, it has to actually work. You have to be able to measure what you're trying to measure. It has to actually evaluate the safety and effects of a drug. And here's the funny part. It has to be able to be put on the label of the drug. So you have to be able to say, helps improve daily living skills. You have to be able to say something like that on the label of the drug. So I'm going to give you an example of Rett syndrome. Rett syndrome was lucky enough this year to have the first drug ever approved for Rett syndrome, debut. And this was a very big deal. And one of the big deals about having this drug approved was not just for Rett syndrome, but was for all of us, because all of us with other rare genetic neurodevelopmental disorders, because the way that the drug was approved, the way they ran the clinical trial was brilliant. And some of the people in this room worked on that. Thank you very much, and we appreciate you for that. So one of the major endpoints of that clinical trial was actually a change in behavior, not just behavior, but observable things that you could see in your kid with Rett syndrome. They called it the RSBQ, the Rett Syndrome Behavior Q, whatever that stands for. And so they actually were asking families about what they saw in their child and asking clinicians about the same thing. And it was actually the primary endpoint. It was ranked number one above all other endpoints in that trial. That's a big deal. They weren't measuring seizures. They weren't measuring some other, objective counted thing. They were measuring what was observed in the kids that had Rett syndrome. And it worked. The FDA approved the first treatment for Rett syndrome based on that RSBQ. It measured an aspect of the condition that was very important to caregivers. It was a tool that could measure those concepts that were shown to be important to families and what mattered to them. And it could be described on the label of the drug. So this is something that we can all rely on. This is something that we can think about when we're trying to come up with clinical trial designs for SLC6A1 and for other rare genetic neurodevelopmental disorders. And so what you can see here is this, on the left-hand side, you can see the change from the baseline in the RSBQ. So that if the score goes down, that's good. So what you can see is that on debut, the drug, trofinetide, which is a IGF-1 analog, what you can see is that the score went down 3 times as much as on placebo. The score on that observable behavior quotient. And at the same time, asking in general on a CGI scale, which is a way of asking clinicians or other caregivers, providers, whether a child is doing better or worse in sort of a general way, it actually also increased the score on the CGI-I. So in other words, these sort of not as easily measurable endpoints were measurable and worked, and the drug actually was approved. So what would the endpoints be? What are potential endpoints for SLC6A1? Well, you're already seeing them used in the trial with Ravicti, and also in Dr. Goodspeed's natural history. All of those trials are collecting information not only about the drug, but about which endpoints are good, and which matter, and which are easy to measure, and which are tolerable to the families. But these are some of the things that you might want to consider as potential endpoints for SLC6A1. You have communication, and we do have the ORCA measure. It's an observer reported communications abilities survey. This ORCA measure is, how many people have taken the ORCA in this room? Not very many SLC6A1 families. Okay. So the ORCA is a communication, it's a survey just asking you how your child communicates. It was first designed for Angelman syndrome, and now we have a grant through the FDA to expand it to 12 other neurodevelopmental disorders. This kind of survey is specifically designed to detect teeny little increases in communication abilities. So if a drug worked, you might be able to see a change in whether your child's communicating a little bit better or not. That's one thing. Also, obviously, motor skills, seizures are going to be important. Sleep was in there. Behavior seemed to be really a big deal to families. Daily activities, and then cognition and development. So the two outcome measures that Combined Brain is working on, one is the ORCA, the communication survey. Another one is a measure of toileting abilities called the ORTUS, and that's also a survey asking you teeny tiny little questions about every little thing your kid might do related to toileting abilities. So it might be, does your child indicate that he has to or she has to go to the bathroom? Or does your child indicate that he's uncomfortable in his diaper? It could be as small as that. Or it could be as big of a deal as actually walking into the bathroom and using the bathroom by himself. But every little step in between, we've added to the ORTUS so that if they improve just a little bit, maybe we could measure it. And a lot of parents with other neurodevelopmental disorders talk about this as the number one thing that they care about. So, in addition, we also need to measure surrogate endpoints. So what's a surrogate endpoint? A surrogate endpoint is a marker. So it's not the actual endpoint, like the ability to use the toilet, for example, or the Rett syndrome behavior quotient, but it's more like a biomarker or something that tells you that maybe things will get better in the person's life. So for example, a stroke. If you have high blood pressure, it's well understood that that's a surrogate measure of your risk for having a stroke. So if you're measuring your blood pressure, you treat blood pressure and it goes down, then we expect that your risk of stroke is also going to go down. So how do you find or discover a surrogate endpoint? Surrogate endpoints are complicated. You need to do a lot of natural history. Fill out all those forms at Simon's, please. Fill out make sure that you do any of the other natural history projects that come along. Please do fill out all those surveys. Those are really important. You need that to be able to find a surrogate endpoint. And you need to be able to give blood or give an EEG, get an EEG taken, or some other measure that's important that we might be able to use as an endpoint in SLC6A1. So this has actually worked. An example that Jennifer gave in her talk that I'm simply borrowing right here is in Duchenne muscular dystrophy. The surrogate endpoint actually changed the way that they do the clinical trials in muscular dystrophy, because it's hard to measure the change in muscular dystrophy, but they could measure dystrophin, which is the protein that's made or not made properly. And so if you can measure that protein, then you can predict that that person is going to get better or worse. So how do you do that? You have to have blood samples. You have to have biopsies. You have to participate in all of those trials. In Angelman syndrome, we lucked out, and it sounds to me like SLC6A1 is also going to luck out, because an EEG is a fantastic biomarker. If you can find a biomarker in an EEG pattern, that is non-invasive. EEGs are a pain. All of us who are parents know that, but at least it's not a blood sample. It's not a tissue biopsy. It's not a lumbar puncture. You can do an EEG on a kid and look and see if there's a pattern that correlates with severity in that child. So in SLC6A1, it seems to me that you've got the start of an EEG biomarker. What are you going to need to figure that out? A lot more EEGs, a lot more. And you're going to need all those EEGs plus all those surveys at Simon's, all that natural history data, all the blood also. So with Angelman syndrome, we found that this delta power which is abnormal. An increased delta power is the abnormal sign in Angelman syndrome, and it completely correlated with cognitive scores, meaning that if you could measure a reduction in the delta power, there was a good chance that you were also going to be helping that kid increase his cognition. So not only in Angelman syndrome, not only did we luck out with the EEG in humans, we also lucked out with it in mice. And it seems to me like you've got the same deal going on in SLC6A1. You've got a really nice bunch of EEG type markers that you can see in your mice, meaning that you can study in the mice drugs that might be affecting SLC6A1 and then convert those into human studies really quickly because you have that surrogate endpoint, that biomarker. So how do you do that? So Combined Brain and Simon's, we collect biosamples. We'd love to have your children's blood, dried blood spots, urine, and if you have any cerebrospinal fluid lying around, we'll take that too. What are we going to do with your plasma? We're going to do proteomics, metabolomics, methylomics, and maybe even throw in some exosomes. And doing that, we hope we'll be able to find biomarkers in some of those samples that'll correlate with severity. So if something got better in those biomarkers, maybe it could be a surrogate endpoint for a clinical trial. Same thing with your EEGs. Combined Brain is right now organizing an EEG bank. We have so many people in this room who have been involved in that. We're hoping to put hundreds of EEGs in an EEG bank. We hope to link it to the phenotype data at Simon's and everywhere else so that we can actually look to see if those EEGs do have the exact kind of surrogate endpoint that we're hoping to find in SLC6A1. So please support the EEG bank by getting the EEGs done on your kids and then submitting them in. So why do we care about endpoints? This is to summarize the beginning of the talk at the end of the talk. This is my worst nightmare, that a good drug can fail if the endpoint is wrong. That has happened. That would be horrible. If we went through all the work, all the science to find a drug that actually helps, and we can't show it because we picked the wrong way to measure it, that would be horrible. So we need the endpoints. And not only that, clinical trials cost more if you don't have a good endpoint. It makes pharmaceutical firms have to spend more money, and it makes them drop out of the business because they can't afford to keep up. So we have to have good endpoints. And if you don't have a good surrogate marker, it can take a long time to have a clinical trial. So if you have a good surrogate marker, like your EEG or maybe one of those blood ones, then you could do your clinical trial hopefully faster. So that is it. And I just want to say thank you so much to everyone, and thank you very much for having me here.